Welcome to the MS-Perspektive podcast, Perspective with a K as I'm German. I'm Nele von Horsten, MS patient, patient advocate and author. I'm bringing you interviews, inspiration and information about living with multiple sclerosis and show you ways how you can positively influence the disease and make the best out of your diagnosis. On ms-perspektive.com you will find the show notes, 11 free tips as a PDF and lots of other information. And now the show begins. Thanks for tuning in again and welcome to episode number 80, B-cell depletion. Ocrelizumab, Ocrevus, Ofatumumab, Kesimpta and Bonspri, Rituximab, Mabthera and Rituxan, and ublituximab, Briumvi for active RRMS and SPMS and early PPMS. B-cell depletion therapies such as Ocrelizumab, Ocrevus, Ofatumumab, Kesimpta, Bonspri, Rituximab, Mabthera, Rituxan, and ublituximab, Briumvi have become important tools in the treatment of multiple sclerosis. These treatments specifically target and deplete B cells, a type of immune cells involved in the inflammatory process of MS. B-cell therapies are considered to be some of the most specific and potent disease-modifying therapies available today, offering a tailored approach to reducing disease activity and progression. In this podcast, we will explore how these therapies are classified within MS treatment options and what their approval status and efficacy mean for different patient populations. Please remember that I can only provide an overview here. Your neurologist and your MS nurse should advise you in detail on the right therapy for you. This is because they know your general state of health, and you should also talk about your goals, wishes, fears, and preferences so that these can be taken into account. Let's start with the general information as usual. To get a good overview of the major topic of therapy decisions, I recommend that you first listen to episode number 58, Immunotherapy in MS, a guide to efficacy and choice with Professor Dr. Tjalf Ziemsen. There you will find out why you can only compare the various disease-modifying drugs to a limited extent, why it is important to start an effective therapy quickly, why MRI and other examinations are important for assessing progression and provide information about effectiveness, why therapies should be changed as little as possible, but of course if they are not effective enough, why in most cases it is better to start with a highly effective therapy and only switch to a lower category at an advanced age, why in the case of highly active MS it may be more important to start immunotherapy quickly and tackle rehabilitation as a second step, why generics and biosimilars are being used more and more and which approval requirements they have to fulfill, why the risk and side effects of a therapy must be differentiated into unpleasant side effects at the start of the therapy and rare possible risks, and these must be set in relation to the usually irreversible effects of an untreated MS in the long term, why it is important to honestly discuss your opinion, wishes, goals, and fears with your neurologist in order to make treatment decisions together that both sides can agree on, why it is advantageous to be cared for by MS specialists and to stay informed yourself in order to benefit from the new findings and treatment options, and last but not least, why you should continue to a favorable prognosis with your own healthy lifestyle. Another general note. The approval studies for the individual drugs were carried out at very different times. 30 years ago, you had to be more severely affected or more advanced in the course of the disease to receive a reliable diagnosis of multiple sclerosis. Less severely affected people were probably not diagnosed or not diagnosed at first. With ever-improving examination methods such as MRI, even small lesions in the central nervous system can now be seen better. Furthermore, 30 years ago, it was not yet known that neuromyelitis optica spectrum diseases, NMOSD for short, and MOGAD are separate diseases that require their own therapies and sometimes even react negatively to MS medication. They were previously thought to be multiple sclerosis, and MS therapies did not alleviate the disease activity. How are B-cell depletion, Ocrelizumab, Ocrevus, Ofatumumab, Kesimpta, Bonspri, Rituximab, Mabthera, Rituxan, and ublituximab, Briumvi, classified in immunotherapies. There are currently 3 different therapeutic approaches for the preventive, i.e. disease-modifying therapy of multiple sclerosis. The most unspecific is immunomodulation. Migration inhibition already narrows down the path. And the most specific is a depletion of immune cells, whereas B-cell depletion, Ocrelizumab, Ocrevus, Ofatumumab, Kesimpta, Bonspri, Rituximab, Mabthera, Rituxan, and ublituximab, Briumvi belongs to. The DMTs are listed in alphabetic order. Immunomodulation. The therapies weaken the immune system. They have a very broad effect via various factors, e.g. on Th1, Th17, Th2 and irregular, and antigen presentation, as well as on different signaling pathways and possibly via other mechanisms. They attempt to shift the milieu from inflammatory to non-inflammatory. The following DMTs belong to it: dimethyl fumarate with Tecfidera and generics, and diroximel fumarate with Vumerity, glatiramer acetate, known as Copaxone and generics, interferon beta with interferon beta 1a, Avonex and Rebif, interferon beta 1b, betaferon and Extavia, and peginterferon beta 1a, Plegridy. And there's a third one, the teriflunomide, known as Aubagio. And then we move on to the second style of immunotherapies, migration inhibition. The migration of certain immune cells is inhibited. To this one, natalizumab belongs, which is known as Tysabri and Juruku, as well as the S1P modulators, with fingolimod known as Gilenya, ozanimod known as Zeposia, ponesimod known as Ponvory, and siponimod known as Mayzent. And then there's a third category, cell depletion. Developing immune cells die off. Depletion of T cells, B cells, natural killer cells, and monocytes. Alemtuzumab, Lemtrada campus. T and B cell depletion with cladribine, known as Mavenclad Loistatlitak, and B cell depletion with Ocrelizumab, Ocrevus, Ofatumumab, Kesimpta, Bonspri, Rituximab, Mabthera, Rituxan, and ublituximab, Briumvi. What are B-cell depletion, Ocrelizumab, Ocrevus, Ofatumumab, Kesimpta, Bonspri, Rituximab, Mabthera, Rituxan, and ublituximab, Briumvi approved for? Let's start with Ocrelizumab, known as Ocrevus. Ocrelizumab is approved for the treatment of active forms of RRMS and early primary progressive MS, PPMS. The Multiple Sclerosis Competence Network, KKNMS, recommends its use in patients who have already received other immunotherapies, but also in the therapy-naive patients. It is important to demonstrate disease activity through relapses or in imaging through MRI. The disease activity must have occurred within the last 2 years. In the Oratio study, PPMS patients aged 18 to 55 years with an EDSS of 3.0 to 6.5 and a disease duration of less than 10 years, EDSS below 10.0 at screening, or less than 15 years with an EDSS higher than 5.0 at screening, were examined and a benefit was found. In PPMS, patients over 56 years of age with higher EDSS and or longer disease duration, a strict risk-benefit assessment must be made. Tolerability and efficacy have been demonstrated in the Opportunity study. Let's move on to Ofatumumab, known as Kesimpta and Bonspri. Ofatumumab is approved for the treatment of active relapsing forms of MS in adults. Clinical relapses or the presence of at least one gadolinium-enhancing lesion on MRI are prerequisites. What's the case with Rituximab, Mabthera, Rituxan? Rituximab is not officially approved for multiple sclerosis, but is used off-label and is also an anti-CD20 monoclonal antibody. And last but not least, ublituximab, Briumvi. Ublituximab is approved for the treatment of active relapsing forms of MS in adults. Clinical relapses or the presence of inflammatory activity detected by MRI are prerequisites. A careful risk-benefit assessment should be made before starting any B-cell depletion. Different information or recommendations are possible from country to country. What is the situation for special patient groups? Let's start with children and teenagers. The NEOS study is currently comparing Ofatumumab with Siponimod and Fingolimod in a double-blind triple-dummy treatment with 1:1:1 randomization. In other words, an equal number of underage MS patients will be randomly assigned to one of the groups and receives all 3 drugs, with 2 of each always being placebo and only 1 being effective, with the aim of ultimately having 40 minors per drug in order to then compare the data. The aim is to more quickly approve effective drugs for children and adolescents who are often affected by highly inflammatory MS. Children and adolescents between the ages of 10 and 17 can participate and, as of September 2024, and can be included in the study. 13 countries are participating in that study. Let's move on to pregnancy and breastfeeding and the recommendation of the European, the EMA, and the American Regulatory Authorities, the FDA. Women who want to have children or are of childbearing age should use reliable contraception during anti-CD20 therapy. If you are receiving Rituximab, Mabthera, Rituximab, Rituxan, or Ocrelizumab or Ocrevus, you should continue to use contraception for 12 months after the last treatment. For Ofatumumab, Kesimpta, this should be for at least 6 months. In the USA, 6 months of contraception is sufficient for Rituximab and Ocrelizumab. Breastfeeding is only recommended after careful consideration with Ocrelizumab and Rituximab. After birth, it is recommended to not breastfeed during the first days with Ofatumumab. After that, breastfeeding is possible, especially if treatment was continued until the end of pregnancy. What is the recommendation of the DMSKW, the German MS Fertility Register? The recommendation is based on the current data situation and experience of the DMSKW. There are an increasing number of reports of women becoming pregnant shortly after receiving anti-CD20 antibodies without an increased risk of miscarriage, malformations, or stillbirth. Therefore, the recommendations for women treated with Ocrelizumab, Ocrevus, Ofatumumab, Kesimpta, Bonspri, Rituximab, Mabthera, Rituxan are being relaxed. Rituximab and Ocrelizumab are completely eliminated from the body after 4 to 5 months, Ofatumumab after 2 to 3 months. It is unlikely that the antibodies will pass to the child during the first trimester of pregnancy. After medical consultation, pregnancy can be planned as early as the next cycle, after the last dose of Rituximab or Ocrelizumab. Ofatumumab can continue to be injected until the pregnancy test is positive and then paused. In rare cases, anti-CD20 therapy can be continued during pregnancy, in which case the newborn's blood should be examined. If there are abnormalities, the blood values must be monitored further and examinations may need to be postponed. Let's move on with breastfeeding. Breastfeeding is not generally contraindicated during anti-CD20 therapy. Breastfeeding should be avoided during the first few days after birth if Ofatumumab is used, but is otherwise possible. If Ofatumumab has been used up to the end of pregnancy, breastfeeding is allowed immediately after birth. There is insufficient data available for ublituximab Briumvi due to its recent approval. Who should avoid Ocrelizumab, Ocrevus, Ofatumumab, Kesimpta, Bonspri, Rituximab, Mabthera, Rituxan, and ublituximab Briumvi? Anti-CD20 therapies should not be used if you are allergic to the active ingredient or any other components of the medication, or if you currently have a serious infection. Special precautions are needed for chronic infections such as HIV or hepatitis B/C, as the therapy could weaken the immune system. People who are prone to infections such as frequent bladder infections or lung infections. People with a weak immune system, for example due to cancer or other diseases that affect the immune system. Previous cancer. In this case, the treatment should be discussed with the oncologist. Pregnancy or breastfeeding. If you had frequent MS relapses before pregnancy, therapy can be resumed during breastfeeding, but ideally not until 1 to 2 weeks after birth. Children and adolescents under 18 years of age, as there is insufficient safety information. Okay, let's move on to Ocrelizumab. For people with progressive MS for more than 15 years or with a degree of disability above 6.5, it should be carefully considered whether treatment is appropriate. Ofatumumab and ublituximab. In people over 55 years of age or with a degree of disability above 5.5, safety and efficacy have not been sufficiently studied. Here too the risk should be carefully weighed against the benefit. How do Ocrelizumab, Ocrevus, Ofatumumab, Kesimpta, Bonspri, Rituximab, Mabthera, Rituxan and ublituximab Briumvi work? These therapies also affect certain T cells and other immune cells. They reduce certain T cells, CD20 DIM T cells, and halve the number of T cells in the spinal fluid. They reduce pro-inflammatory substances, interferon gamma, and interleukin-17, and slow the growth of T cells. They reduce pro-inflammatory proteins, interleukin-12 and interleukin-6, and increase an anti-inflammatory protein, interleukin-10. What about Rituximab? Any antibody that is 65% human that helps to destroy cells through a special immune system protein complement. It belongs to the first generation of such therapies. Ocrelizumab, almost completely human, over 90%, destroys cells by activating immune cells. It is an advanced therapy and belongs to the second generation. Ofatumumab, completely human and also works via the complement system. It belongs to the third generation. Ublituximab, a third generation antibody that works similarly to Ocrelizumab by activating immune cells. How is it taken? Let's start with Ocrelizumab, Ocrevus. Ocrelizumab is given as an infusion at a dose of 600 mg. Initially, you will receive 2 doses of 300 mg each at 14-day intervals. After that, you will receive a 600 mg dose as an infusion every 6 months. The amount of medicine remains the same regardless of weight, gender, or origin. Ocrevus can also be administered subcutaneously. This means that Ocrevus is administered by a doctor or medical professional as an injection into the abdominal wall. The injection takes about 10 minutes. Care is taken to ensure that the injection is only given into healthy skin areas. After the first injection, you will be monitored for at least an hour to detect any possible side effects. If any reactions occur, the injection can be stopped. Ofatumumab, Kesimpta, Bonspri. Ofatumumab Kesimpta is given by injection using a prefilled syringe or pen. Each syringe or pen contains 20 mg of the active ingredient in 0.4 ml of solution. The recommended dose is 20 mg, with the first 3 injections given in weeks 0, 1, and 2, each 7 days apart. From week 4, the injection is given once a month. You can give yourself the injection under the skin subcutaneously. Suitable places for this are the abdomen, thighs, or outer sides of the upper arms. Rituximab, Mabthera, Rituxan. Patients are treated with 500 or 1000 mg Rituximab IV every 6 to 12 months. Ublituximab, Briumvi. Ublituximab is given as an infusion in diluted saline solution. Before the infusion, you will receive medication, cortisone, antihistamine, possibly paracetamol to avoid side effects. The infusion schedule, there's a first infusion was 150 mg over about 4 hours, then 1 hour of observation. The second infusion is with 450 mg after 2 weeks, and it takes about 1 hour plus 1 hour of observation. And all subsequent infusions are given every 6 months, same schedule as the second infusion. The most important thing is that the infusion is done under medical supervision and that any side effects are monitored. How effective are Ocrelizumab, Ocrevus, Ofatumumab, Kesimpta, Bonspri, Rituximab, Mabthera, Rituxan, and ublituximab Briumvi? Let's start with Ocrelizumab. The treatment reduces the number of active MS lesions by 89% compared to placebo. The effect is seen between 4 and 8 weeks after the first dose. Over 24 weeks, Ocrelizumab reduced the risk of relapses by 80%. For PPMS, it slowed the disability by 25% compared to placebo. The OPERA 1 and OPERA 2 studies about relapsing MS. Ocrelizumab reduced relapses by 46 to 47% compared to interferon beta 1a. It also reduced disability progression by 40%. MRI scans showed a 94 to 95% reduction in new active lesions compared to interferon beta 1a. Brain volume loss slowed by approximately 23%. In other words, you can also look at 100 patients. 67 of these patients remain relapse-free, even on interferon beta. In the Ocrelizumab group, a further 13% remained relapse-free. Looking at the same 100 patients, 82 remained at the same level of disability as measured by the EDSS, the Expanded Disability Status Scale, during the clinical trial period, including the interferon beta 1 group. 7 people in the interferon beta group deteriorated who remained stable on Ocrelizumab. What about Ofatumumab? The mirror study was done with relapsing MS, RRMS, and tested against placebo. 99.8% fewer new active brain lesions between weeks 8 and 24. All dosages were tested. 100, 300, and 700 milligram were equally effective. Esclepsios 1 and 2 phase 3 studies comparing Ofatumumab with teriflunomide. The relapse reduction was 50.5% and 58.5% respectively. The confirmed increase in disability was reduced by 34.4% within 3 months and by 32.5% within 6 months. 35.2% of patients even showed an improvement, i.e. a reduction in their disability after 6 months. There were 93.8% and 97.5% fewer new active lesions and 82% and 84.5% fewer new or enlarging lesions. What about Rituximab? There was a study on relapsing MS. In a study of 104 patients over 48 weeks, Rituximab was compared with placebo. The primary objective was to reduce the number of active lesions in the brain. Result: 91% fewer active lesions. The study on primary progressive MS, which was named Olympus, was done with 439 patients. They were treated with either Rituximab or a placebo in a 2-to-1 ratio. The primary objective was the time to disease progression over 96 weeks was investigated. There was a difference, but not a significant one. Further objectives: change in the number of lesions, damage in the brain over 96 weeks. This objective was achieved. And last but not least, ublituximab. It reduced relapses by around 45% compared to teriflunomide in relapsing remitting MS, but there was no difference between the 2 DMTs in relation to disability progression. Professor Dr. Gavin Giovannoni, an MS expert from the UK, has graded his MS selfie-cards on a scale of 1 to 10, with 1 being low efficacy and 10 being maximum efficacy. In his estimation, Ocrelizumab, Rituximab, and ublituximab score 7 for preventing relapses, and Ofatumumab even 9. When it comes to preventing long-term disability, Ocrelizumab, Ofatumumab, and Rituximab score 8 for avoiding long-term disability, whereas ublituximab scores just 4. What are the risks and side effects of Ocrelizumab, Ocrevus, Ofatumumab, Kesimpta, Bonspri, Rituximab, Mabthera, Rituxan, and ublituximab, Briumvi? Typical side effects for B-cell depleting therapies are reactions during the infusion, such as itching, skin rash, or breathing problems, as well as systemic reactions such as headache, fevers, muscle pain, myalgia, chills, and tiredness, which occur mainly within the first few doses, as well as infections. Infections of the upper respiratory tract and urinary tract infections should be monitored. The risk is higher for already more disabled patients. The level of immunoglobulin M, a protein involved in immune defense, can also decrease in the blood. Safety precautions, lab parameters. The clinical neurological checkup. The clinical neurological checkup must be carried out quarterly. Basic laboratory program. Routine laboratory parameters. Blood count plus differential blood count must be checked every 3 months, including determination of CD19 plus and or CD20 plus B cells. In addition, the immunoglobulins, important antibodies in the blood, are measured every 6 months, especially IgG. If your IgG level drops, you may become more susceptible to infections. In this case, your doctor will decide whether treatment should continue. If you experience frequent infections, you may be given additional immunoglobulins. Radiological monitoring. An MRI of the brain should be carried out once a year to assess the success of the treatment and to assess possible complications of the therapy that are relevant for differential diagnosis. Contrast agents are only necessary if there are indications of a worsening of the disease or if there is no standardized initial MRI. Vaccinations. Vaccination success may be reduced with B-cell depleting therapies such as Ocrelizumab, Ocrevus, Ofatumumab, Kesimpta, Bonspri, Rituximab, Mabthera, Rituxan, and ublituximab, Briumvi. Therefore, all important vaccinations should be updated or completed 2 to 4 weeks before starting treatment. If necessary, vaccination success can be checked with a blood test. Live vaccines, such as some travel vaccines, should be avoided during treatment with these medications. Even after the end of therapy, they should only be given in special cases and only after B cells have fully recovered. Vaccination against herpes zoster, which leads to shingles, is recommended for patients with immunotherapy from the age of 50. In this case, vaccination with the inactivated Shingrix vaccine is recommended. Last but not least, my sources. I used the following sources to create the content. The lecture on pediatric multiple sclerosis by Professor Dr. Jutta Gärtner as part of the Multiple Sclerosis Management Master's Program. The lecture on B-cell depleting therapies by Professor Dr. Xavier Montalban as part of the Multiple Sclerosis Management Master's Program. The quality manual of the German KKNMS on Ocrelizumab, Ocrevus, Ofatumumab, Kesimpta, Bonspri, and ublituximab, Briumvi. The MS Selfie Infocards by Professor Dr. Gavin Giovannoni. The German Multiple Sclerosis and Fertility Registry, DMSKW. And the German DSEMS information on Ocrelizumab. One final note. Please remember there is no one great medication that helps everyone, but it must always be weighed up what suits a particular person best. Other illnesses, personal goals and preferences must also be taken into account. Your neurologist and MS nurse are the right persons to talk to and can make individual recommendations. This podcast is for information purposes only and does not constitute a recommendation. What helps one person may not help another. I hope that together with your neurologist and MS nurse, you will quickly find the right immunotherapy for you, and that you can lead a fulfilled, happy and self-determined life with MS, supported by a healthy lifestyle and a dose of fortune. By the way, you may also want to look at the podcasts on the other DMTs. Number 61, dimethyl fumarate with Tecfidera and diroximel fumarate with Vumerity. Number 65, glatramine acetate with Copaxone Brabio. Number 68, interferon beta with Avonex, Betaferon, Extavia, Plegridy and Rebif. Number 70, teriflunomide with Obagio. Number 72, natalizumab with Tysabri Turuku for active relapsing remitting MS. Number 74 with SMP modulators, fingolimod gelenia, oxanimod ceposia, ponesimod ponvri, and ciponimod mason for active RRMS and SPMS. Number 76, alemtuzumab, lemtrada campus for highly active MS. And, last but not least, number 78, cladribine, mavenclad loistad litac for highly active MS. With this, I'm actually at the end of immunotherapies for multiple sclerosis, at least for now. Let's see what new therapies might be up on stage in the next years. And by the way, next time I will be talking about navigating treatment and support for MS, NMOSD and MOGAD in Montenegro with Dr. Sanja V. Gluscevic. This will be very interesting. It's a very lovely lady and a very heartwarming neurologist. So please tune in and stay as positive and healthy as possible. And see you next time. Bye. Thank you for listening today. I hope you found it helpful. You may also be interested in the previously published episodes and posts, which you can find at ms-perspektive.com/podcast. Perspective with a K. You can also get a free PDF with 11 tips for your positive impact on MS at ms-perspektive.com/newsletter. If you'd like to get in touch, you can reach me at nele@ms-perspektive.com or on social media. See you next time.